So she could use the dilators. The doctor said that her tissues looked great, but every time her partner leaned in for a kiss or a little hug, she would start to brace or freeze. And this wasn't because she didn't love him. It wasn't because he wasn't a patient partner. It was because her nervous system continued to brace for the pain, even if her tissues had been healed. The answer isn't about willpower, and it's not about positive thinking. It's about rewiring the reflex. And in this video, I'll talk about the 2 top ways that helped intervene on this pain pathway for my client who was overcoming vulvodynia. I'm Kayna Cassard. I'm a sex therapist and a pelvic pain mental health coach, and I dealt with vulvodynia for over a decade. But I found solutions, and I help people heal from painful sex and reconnect with their body without pressure, without shame, and without feeling like they need to be fixed first. So if you've been told that your tissues are healing or have totally healed, but sex still hurts, it doesn't mean that you're imagining. It means that your nervous system just hasn't caught up yet, and you just need the right tools to figure out how to do that. The intervention is to help the body learn what the mind is trying to tell you all along. But it's way easier said than done. And I try to make this super accessible for people. So we use 2 tools that I teach all of my clients in my coaching programs, and they changed everything for her. Let me tell you a little bit about her, and then we'll get into the tools in a moment. So Jessie, she's in her early 30s. She works in a high pressure job. She loves her partner. They have an amazing relationship, except for this one thing. She made amazing progress with her dilators. Her doctor told her that everything looked fine with her tissues, but even casual intimacy, like a kiss that felt like it was too long, was triggering her body to brace for a pain response. It made her go into a sexual avoidance cycle, which is what most of my clients end up getting into before they come to see me, because pelvic pain patients like Jessie were constantly bracing for pain even when they didn't want to. And it was because the body learned that intimacy, any kind of intimacy, might lead to arousal or might lead to sex and penetration, which could either be physical pain or emotional pain like disappointment, pressure, rejection, shame, guilt. So logically, Jessie knew she could say no to her partner, but she felt that sense of guilt and that pressure, the internalized pressure, to try to have sex because she wanted to, but also because she wanted to be close and connected with her partner in that way. And she ended up feeling so much confusion about the situation. She wasn't afraid of her partner, really. She was afraid of what happened after the kiss. Her body expected sex, and her body still equated sex with pain. So the brain pain pathway gets activated when you've experienced pain for longer than 6 months. And even if your tissues are healed and you can do it with your dilators, starting to step into a what seems like uncontrolled, unpredictable situation as sex is going to activate the brain pain pathway again if you haven't taught your body how to get to neutral and then to pleasure. So not all sex feels good, especially when you're coming out of dealing with chronic pain. So when I ask my clients what turns them on after they've been working through their vulvodynia treatment, a lot of times they don't really know because their body has associated so much of what they did in the past or so much of what they think should turn them on with pain. The rest of the landscape of the arousal system is just totally either empty, unsure, or scary feeling. So they haven't had a chance to define what actually feels safe, exciting, and nourishing for them. So that's why I use the arousal architecture as a system to help teach them what uniquely turns them on, especially if they've been challenged with dealing with pain, pressure, disappointment, shame, guilt. I help them figure out what does turn them on, not what should turn them on. So when I was teaching Jessie about these different aspects or different dimensions of the arousal architecture, she thought that there was only one dimension of the arousal architecture, of her arousal system, and that is sexual stimulation. But the problem is that sexual stimulation and expecting that we should just be turned on by the idea of sex or our partner's bodies or a sexy situation mainly works for people who have what's called the spontaneous arousal system. The spontaneous arousal system is when a person can easily anticipate pleasure with a sexual stimulation. That could be physical stimulation, or it could be like fantasy stimulation. Now, for people like Jessie and for most of my pelvic pain clients, they have what's called the responsive arousal system. The responsive arousal system sounds like exactly what it is. It is a response to pleasure. But if you have been having a lot of pain and you haven't had a lot of pleasure and you don't even know what pleasure looks or feels like anymore, it's going to be really hard to expect your body to have that spontaneous arousal. And it might even feel hard to have a responsive arousal, to have a response to pleasure if everything you've experienced has been painful. So that's where the arousal architecture really helped Jessie out. So instead of expecting that the sexual dimension is the one dimension that should be working for her, we explored the 4 other dimensions. And these are the 4 areas that nobody talks about because I developed this specifically for pelvic pain clients, and now it's expanding to kind of anybody who just wants better sex. So these different dimensions address embodied experience, mental headspace, energetic connection, and erotic exploration. So embodied experience might be something like listening to your body's signals, giving yourself the nourishment it needs in general in order to have a sense of resiliency and body safety. The mental headspace component is looking at not only what lights up your brain when it comes to sex and connection, but also what helps turn down the noise or helps manage stress. The energetic connection dimension could be around a sense of relational safety and commitment, and a sense of maybe even spirituality when it relates to yourself or somebody else. And then the erotic exploration, which is different than sexual stimulation, often is best looked at in a sense of like, how can you bring play into your life? Play into sex, but also play into your life in general, and just like a sense of joy on things that are just unstructured and just being done for the sense of enjoyment. Now, all of these influence desire, but they're often forgot about in the process. And that even happens with sex therapists who prescribe sensate focus as an exercise without teaching the ways in which it can work uniquely for your system. And that's what happened with Jessie. She had gone to a sex therapist who prescribed sensate focus, but didn't teach these other components. Jessie just kind of felt like the sensate focus exercises weren't really landing for her and her body, but she kept doing it because that's what the healthcare provider told her. Overall, the point of the arousal architecture is to help you identify your unique pathways that have been untapped and help you learn how to step into curiosity before expecting pleasure. So Jessie figured out which ones worked for her to help her establish the sense of safety and neutrality, and then work toward pleasure. And she also identified the ones that contributed to pain patterns. And either we just didn't invite those into her play, or we helped her use nervous system tools and trauma-informed somatic interventions to help her nervous system unwire that pain pathway and that pain response to those activities. So if Jessie's process sounds similar to your experience at all, then you might like this introductory course I created. It's called Break Free from Pelvic Pain, and it provides the top 5 interventions that I teach every single one of my clients as they're navigating pelvic pain treatment. You can start today. The link is below, or you can go to kaynacassard.com/breakfree. So the second tool I want to tell you about is to help address the challenge that Jessie was feeling when she experienced a sense of pressure to go from 0 to 60 when it came to intimacy and sex. Meaning, even when she had her tissues healed and she felt like she could use the dilators at the same level that her partner was, when she stepped into intimate experiences and just hoped that pleasure would come, she felt like she was going from 0 to 60. Instead, what helps more is going from 0 to 5 to 10, and going in these small graduated steps in a structured way that utilizes the arousal architecture and incorporates practices that are natural or more common to Jessie and her partner. So the Sacred Experiences Hierarchy is a pacing tool. It's a guide that I help clients identify what works for them uniquely, and then I teach them a structured process in order to integrate the nervous system awareness and regulation tools that helps their body get to a sense of neutral, and then apply those tools and techniques to the kind of intimate experiences that each individual or couple wants to have. So we establish a neutral, safe, non-sexual touch at the bottom of the process. And then we move into exploratory, more pleasure-based experiences in the middle, and then penetrative sex only when the body feels ready and only when they have been able to experience the other activities with neutral or neutral plus, or maybe even pleasure. So with Jessie, we focused on creating experiences, sexual experiences, intimate experiences that just didn't suck. So when she thought about them, she was just like, okay, that wasn't terrible. And that is actually what I'm always helping my clients get to first. And it sounds like such a counterintuitive process, but really, I don't want my clients being like, I had the best sex ever. I mean, yes, eventually I want them to get there. But first, we start with removing the pressure of pleasure expectation. And so what this did for Jessie and for many of my clients is that over time, when her partner started to lean in for a kiss, her body stopped bracing, and she was actually able to melt into and sink into the experience first neutrally, and then she was able to experience the sense of pleasure because she had removed the expectation of pleasure and the expectation that it was going to go somewhere else besides that, just that kiss. She started wanting to be close again, and not because she forced it, but because her body trusted that she had a voice, a boundary, and a path in order to walk down to get to the place that she ultimately wanted. So if Jessie's story sounds familiar at all to you, then hopefully you know that you're not alone, because it's what I went through, it's what all my clients go through. And you're not broken. You just need a structured set of systems that are tailored specifically to people who have had pain experiences and need a trauma-informed, somatically focused neuroscience perspective at overcoming this. So you need practical tools that actually meet you where you're at and help your body learn a sense of confidence to engage in intimacy without pressure or guilt. So in the next video, I'll walk you through the exact system and steps that my clients are using in my coaching program that help them move from painful sex to real joyful connection. I'll see you there.